Welcome, everyone, to episode 4 of the TIMI Talks podcast. This is Nick Marston, here with my co-host, David Berg. On today's show, we'll be joined by the legendary cardiologist and founding chairman of the TIMI Study Group, Dr. Eugene Braunwald. So, David, the other day, a friend asked me if I could help him come up with a name for a trial he's getting off the ground.
I guess that's one of the few perks of having a clinical trialist for a friend.
That's right. It's a short list, isn't it? Do you enjoy the process of naming trials, or do you prefer to let someone else take care of that?
I definitely like to have a hand in it, but I certainly appreciate having a partner in the process. It really can be a lot of pressure. You have to make sure the trial team's happy, the steering committee's happy, the sponsor's happy, and that's not always a totally straightforward triangulation.
Yeah, I remember being asked to name a trial as a fellow, and I took that role very seriously. I came up with Propel, which I really liked, but ultimately the sponsor chose to shut down that program, a decision that, from my understanding at least, was unrelated to the trial name.
At least that's what they told you. So in the end, did you help your friend come up with a trial name?
I did, yeah. I mulled it over for a few days and got back to him with some options that fit with the topic of the trial. Colossal was one that I liked, although admittedly it's a bit of a misnomer for a single center study. Collide was another, so I had a few.
Yeah, well, I guess I'd have to see the full spell outs of those, but I agree. Those are some solid trial names.
Yeah, I thought so, but then I emailed them to him, and he replied that he'd already chosen a name from a list provided to him by ChatGPT, and I have to say the names were pretty good.
That's incredible. That's genius. Nick, I have to confess something, which is that I've never actually used ChatGPT.
That does not surprise me.
Yeah, it may not be a surprise to you, but for everyone else, maybe that's a surprise. I don't know. Have you used it?
I have, yeah. In fact, the first time I used it was to find those 2 restaurants we went to in New Orleans during ACC. So it was a small ask of ChatGPT, but I thought it did the job pretty well.
Yeah, well, I would concur that those were some solid recommendations, and I have to say I'm not surprised that you sort of beat me to using ChatGPT. One of the things is that friends, that I do have a couple of friends who've been early adopters with this, and they have suggested that there's all kinds of ways that ChatGPT might actually improve my quality of life, or at the very least, add more humor to it.
Yeah.
As you know, our friend Brian Bergmark, who is an interventional cardiologist here at the Brigham and also a TIMI investigator, he recently texted a screenshot of a response he got from ChatGPT, where he asked for a summary of the evidence for TAVR in moderate aortic stenosis, but specifically in the style of Donald Trump.
Nice.
I have to say it was pretty hysterical. So I guess that's one possibility. But maybe naming a trial might be a good way to dip my toes into the ChatGPT waters. I don't know.
Yeah, I think so. Speaking of good trial names, the Reprieve trial just released top-line results this week, and that's always exciting in the clinical trial world.
Yeah, no, that's right. For all of our listeners, Reprieve was an NIH-funded international cardiovascular outcomes trial that tested pitavastatin at a dose of 4 milligrams per day as compared with placebo in patients living with HIV. And what's interesting is this is the first large-scale study to test this primary prevention strategy in this particular population.
Yeah, and these primary prevention trials can be challenging for several reasons, but they really are necessary for the field, and it's really great to see the NIH take on trials like this that will have a direct impact on patient care.
So, I'm going to press you, Nick. If you can unpack that for our listeners a bit more, what is it that makes primary prevention trials challenging, specifically from sort of a trial design and execution standpoint?
Yeah, so a couple of things. I mean, anytime you're studying a lower risk population, it's going to take longer to accrue the number of primary endpoint events that you need to properly power that trial. And so to compensate for the lower event rate, you need to design the trial with some combination of more patients and longer follow-up. Of course, both of these are going to increase costs, and so can make primary prevention trials more expensive. However, I think this increased cost can often be justified as the results will apply to a larger population more broadly.
No, I do think that's an important point. And I think you hit on the right things, which is that it means more patients and longer follow-up. But in addition to those two things, there's often, there'll often be some risk-enhancing inclusion criteria, or what we call enrichment factors, to try to help boost the event rate in the study population. And in some cases, the relevance of that risk enhancer is exactly what's being tested. So a good example of that was the Jupiter trial, which was a trial that enrolled apparently healthy patients with an LDL cholesterol less than 130, which at the time was considered to be reasonable LDL control, but who also had an elevated high sensitivity C-reactive protein. And that study randomized patients to either a high intensity statin, rosuvastatin, or placebo.
Yeah, that's a really good example, and it'll be interesting to look at the Reprieve data and the results kind of in the context of Jupiter, and kind of look at those two side by side. Another challenge in primary prevention statin trials nowadays is the lack of a sponsor or pharmaceutical company that can financially back the trial. Since statins are first line therapy for lipid lowering and primary prevention, there's no doubt that this is the right intervention in this trial. However, because it's generic, companies are not incentivized to really fully fund a statin outcomes trial. And so this is where the NIH and other research institutions play such a critical role in funding these trials that answer really important clinical questions for our patients.
And so, exactly as you implied, Nick, the Reprieve trial did go on for longer than is typical for a lipid-lowering trial. It's starting all the way back in 2015 and just ending. And so, thinking about the study design, the investigators enrolled nearly 8,000 total patients between the ages of 40 and 75. And I'll note that about 30% were women. And importantly, all of the patients were on antiretroviral therapy and had CD4 counts above 100. And then with respect to their cardiovascular risk, they had low to moderate traditional risk for atherosclerotic cardiovascular disease that would not typically warrant statin therapy. And so, Nick, as you're sort of digesting and sorting through all of the trial design issues, was there anything about the design of the trial that really stood out to you?
Yeah, well, I think, using Aaron Bahula's quote from last episode, it's really important to consider the intervention, the population, and the outcome. And I think the first two are certainly worth noting here. So while the intervention of a statin is very well established, 4 milligrams of pitavastatin is just a moderate intensity statin, and not typically one that I would reach to first in the clinic. An additional way that you could increase power of a trial and therefore decrease cost would be to increase the treatment effect. And since we know that high intensity statins will provide greater LDL reduction, typically more than 50%, and that translates to greater risk reduction, you may imagine a scenario where you would want to use a higher intensity statin to kind of increase that treatment effect. However, I also understand that high intensity statin could be viewed as perhaps overkill in this lower risk population. So I think choosing a moderate intensity statin is completely reasonable, but I'm sure that was something that was discussed at the onset.
Yeah. And then what about the population? Anything that stood out to you there?
Yeah, the population gets tricky in a primary prevention trial because a lot of patients already meet a guideline for recommending statin therapy. So to maintain equipoise, the investigators had to exclude a lot of patients here. Anyone with ASCVD, diabetes, elevated risk for ASCVD, or LDLs over certain thresholds. Those are all patients who already, meet guideline recommendations for statin therapy. So with all of these exclusions, you're really left with a pretty low risk population. And so that's where the HIV status can really help to enrich the trial and increase the event rate, as you mentioned.
And so the big news, of course, just to cut to the chase, was that Reprieve is positive. It was actually stopped early for overwhelming efficacy after an interim analysis revealed a 35% relative risk reduction in major adverse cardiovascular events among patients who were randomly allocated to pravastatin as compared to placebo. And so this was the recommendation of the Data Safety Monitoring Board, the DSMB, and it was accepted by the NIH, the sponsor.
Yeah, I mean, 35% risk reduction is really a home run for treatment benefit. And anytime there's an interim analysis that changes the course or duration of a trial, it's always interesting to think about what discussions took place behind closed doors at the DSMB meeting and prior meetings that ultimately led to these recommendations. David, can you talk a little bit about how these decisions are made?
Yeah, I'd be happy to. So, in addition to having ongoing safety reviews in clinical trials, trials will often have pre-specified interim analyses to look at the efficacy of an intervention. And the concept is simple. If at some point it becomes clear that a given intervention is going to work, that there's going to be a significant and meaningful impact on outcome or outcomes of interest, and that occurs before the target enrollment is reached, in theory, it becomes unethical to then continue the study. And so that sounds straightforward, but it turns out that it's not, and it's not for a number of reasons.
Yeah, it does sound relatively straightforward, but I can't tell you how much time we spend at TIMI grappling with this before a trial and as we're finalizing the DSMB charter. And so can you give the listeners some examples of the challenges?
Yeah, sure. So, one of the issues is that the estimated effect size of an intervention naturally fluctuates as endpoints are accrued throughout the study. But when you're reviewing the data, when you're from the perspective of the DSMB, you only get a snapshot in time. And so the confidence limits around that effect estimate really need to be sufficiently narrow that you can be certain that there's a real effect on the endpoint before you're going to say, hey, let's go ahead and stop this trial. Another issue is that the more times you look at the efficacy data, the greater likelihood that you're going to just have a chance positive result. And so to be statistically rigorous, there's often what are called alpha spending statistical procedures that are baked into the analysis plan. And what that means is that if you formally look at the efficacy data before the end of the trial, the threshold for achieving statistical significance with subsequent reviews of the data, including at the very end of the trial, it should be higher for the most part.
Great. And so what does that mean kind of in concrete terms?
Yeah, I mean, I think to sort of be very sort of literal about it, rather than having a threshold of p less than 0.05 to declare statistical significance, if there were previous looks at the data and you spent some of the alpha, it might be that you have to have a p-value that's less than 0.045, for example, to achieve statistical significance. And of course, there are a lot of different ways to design these stopping rules, but the spirit of all these approaches is the same. And I think the last thing to sort of consider if you're sort of wearing the hat of the DSMB is before you stop, you need to consider whether you might be missing an important effect on a harder clinical endpoint by stopping early. And so, for example, there may be a clear reduction in major adverse cardiovascular events, but by stopping early, you might miss out on a reduction in cardiovascular death. And there's certainly plenty of examples of where that's happened in the past.
Yeah, I think it'll be very interesting to see if they hit for cardiovascular death. As you said, when we set the criteria for stopping the trial early for efficacy, we often want to make sure the trial will be significant for cardiovascular death. The last thing you want to do is stop early for primary endpoint efficacy and then just miss on CV death. And perhaps if you had just continued the trial as planned, you then would have hit for CV death. And the reason I think CV death is so important is it can really help move the needle on clinical uptake, both in guidelines and in clinical practice. And so this will be something to watch for when these data are presented and published.
Yeah, well, I love the teasers, but I'm certainly as excited as you are to really dive into the details once they become available. So switching gears a bit, today we are incredibly lucky to be joined by the founding chair of the TIMI Study Group, Dr. Eugene Braunwald. And I don't think Dr. Braunwald actually needs an introduction. In fact, I remember he actually cut me off one time when I really dragged out an introduction of his, that he was giving a talk to the residents here at the Brigham. But I guess I'll just quite simply, I'll say that there is perhaps no other person who has had a greater impact on this institution or on the field of cardiovascular medicine than Dr. Braunwald. And so in a departure from our usual format of bringing on a discussant to unpack a specific trial, we'll actually just be asking Dr. Braunwald about his reflections on his career in cardiovascular medicine, clinical trials, some of his scientific discoveries along the way, and especially about the origins of the TIMI Study Group. So let's go ahead and bring him on.
Thanks so much for coming on the Timmy Talks podcast, Dr. Braunwald. It is really such an honor to have you join us.
Well, I appreciate the invitation.
Well, before we get into the early days of the TIMI Study Group, I want to start with some of your major career moves that led up to that point. You've, of course, not only had an incredibly impactful research career, which we'll get into, but you also served in many leadership roles along the way. In fact, at just 35 years of age, you were already the chief of cardiology at the NIH. And then at 39, you were the founding chairman, the Department of Medicine at UC San Diego. And then at 43, you came here to the Brigham and Women's Hospital to chair the Department of Medicine, a position you held for 24 years, during which time you were the founding chair of the TIMI Study Group and editor of the premier cardiology textbook that bears your name, Braunwald's Heart Disease. And so in thinking back on the arc of your very illustrious career, what would you say was one of the keys to your early success and really rapid rise in academic cardiology?
Well, it was serendipitous. So I was born in Vienna, and when the Nazis moved into Austria, our family, nuclear family, escaped. And we became refugees, not immigrants. And my parents, who were in their mid-30s, had to start life all over again in the United States. So it really is something that my brother and I felt very strongly that they were our role models. Now, that's one aspect, role models of working extremely hard, being the normal. The other thing was that when I started college, it was just after the completion of World War II, and there was a rush of veterans, and I was able to complete high school and college in 5 years, gained 3 years. Then went on to medical school, be the youngest in my class, because of the fact that I had gained these 3 years. And so I was able, in my post-graduate training, to take 3 fellowships in cardiology. One at Mount Sinai in diagnostic cardiology. The second one was with Professor Andre Cournand, and I was there the year before he won the Nobel Prize for developing cardiac catheterization. And thirdly, at the NIH, where I worked in cardiovascular physiology with Stanley Sarnoff. So I had these wonderful mentors, and I had the time to do it over the course of 3 distinct fellowships. And then there was a lot of luck involved, a lot of luck.
Well, of course, you would point to the luck, but we certainly know that that foundation and really hard work is really at the core. And you know, thinking about your personal origin story, I think some of the things you said resonated. And you know, my own grandfather, I think we've spoken about this before. He had to flee Lithuania himself to avoid the Holocaust. And first of all, I'll say that, you know, thank you for sharing these stories. I think for him, he really wasn't able to talk about that time in his life until he was well into his 90s. And even then, you know, it was incredibly emotional for him. But I think the themes you talked about being a refugee and sort of some of the immigrant themes that sort of drive your work ethic, those certainly resonate. I saw that in my grandfather, and he certainly passed that along to my father and to my siblings and myself. So I'm going to pivot a little bit and talk about not just the origins of you, but the origins of TIMI. And on our first podcast, we shared that the NHLBI had actually approached you about leading a collaborative research effort to test emerging cardiovascular therapies in multi-center trials. But I have to admit that, you know, when Nick and I talk about those early days, it's sort of like sharing old family stories that you've heard, you know, so many times that you almost feel like you were there, but, you know, in fact, you really weren't there. So I thought it might be nice to hear directly from you about the early days of TIMI and perhaps about some of the early observations that motivated your work.
Okay. I'll start out to tell you that before the development of coronary care units, which happened in the very early 60s, the concept of acute myocardial infarction was that it was a sudden event, like throwing a light switch and closing the lights. Now, at that time, I had this job at NIH, but I also had a teaching professorship at Georgetown. And so I saw lots of MI patients in two facilities. And I noticed a number of patients in whom the onset of MI was stuttering. It occurred over several hours. They might have had unstable angina, which got worse. They might have had severe chest pain, which got better and then worse and cycled. So it brought the idea to me that maybe if you had patients who developed an infarct slowly and you got to them early, you might reduce infarct size. Well, we moved to UC San Diego, as you mentioned, and started some experiments there with a terrific fellow, Peter Morocco. And what we found in open chest anesthetized dogs, that if we clamped the coronary artery, open chest, and then opened it at various time intervals in different animals, we found that the longer we waited, the larger the infarct. Conversely, the sooner we opened the vessel, it stands to reason, the smaller the infarct. We also found that with a beta blocker, propranolol at the time, aided this. So when we discovered that infarction was reduced, I would say that that established a hypothesis. So this was a bingo observation, at least for me, and published this in Circulation. So, of course, at that time, which was in 1971 is when this paper appeared, it was not possible to convert this into a clinical observation because angioplasty had not yet been invented by Grunzig. And but there was a way of opening the vessel, and that was with fibrinolytic therapy. And on a trip to Moscow, I met the Undersecretary of Health, a cardiologist by Eugene who was talking about injecting streptokinase in, intracoronary to open vessels. And hadn't done it yet, but we had that discussion. And of course, a year later, he had done it, and an excellent example of opening up a total occlusion in the right coronary artery. And I think that swayed many people, including us, to say, okay, let's go with it. And I brought this to the attention of the NIH, and you know, when you do that, no good deed remains undone. And I had to lead this effort. And we called it thrombolysis in myocardial infarction. And we took patients with STEMI, old patient with STEMIC, and injected intravenous streptokinase, which was easily available and inexpensive, and compared it to TPA, which was much more expensive, a brand new concept of using molecular biology to create a drug. And we observed a doubling of the opening of occluded vessels. to get into the trial, you had to show a pre-treatment of total occlusion, and then did you open it? And we came up with a TIMI score for blood flow from 0 to 3. And we found that if you open it, which was TIMI flow 2 and 3, there were twice as many patients. 61%, 62% of the patients showed an opening, and exactly half, 31%, showed an opening with streptokinase. So I think that that was, to me, a very important trial.
Yeah, wow. Well, thanks for going through that. It's just so fascinating to hear you talk about the first TIMI trial and how it came to be, and really starting with the observation, clinical observation made at the bedside, then kind of brought to the bench with animal work, and then back to the bedside with a clinical trial, and all the early lessons learned about MI along the way. Of course, there have been many TIMI trials since TIMI 1, and now Mark Sabatine quips that just as we love each of our own children equally, the same is true for all of our clinical trials. However, I am curious to ask if you have any favorites, or at least trials that, in your view, had the greatest impact on clinical practice.
Well, Mark is correct, of course. My great favorite trials were, of course, TIMI 1. And after TIMI, well, we didn't know that it was TIMI 1. It was a trial. And we named it afterwards. It's like World War One. People didn't go into it saying this is World War One, but after it passed, it became World War One. Anyway, so TIMI 1 really put this thing on the map, and it gave cohesion to our small group of 15 top-notch clinical investigators around the country. And I think that that is something that certainly has persisted and has grown as TIMI has grown. So TIMI 1 is important because it showed that you could examine in patients what intravenous therapy would do. Of course, we didn't. It was still early in the days of percutaneous coronary intervention. Another important trial in those early years was TIMI 3, which we got was supported by the NIH from an R01 grant, and that was on non-ST elevation, acute coronary syndrome, so unstable angina and NSTE, myocardial infarction. And we felt that we had shown this benefit of intravenous TPA in patients with STEMI. And what about non-STEMI, which we know even at that time was larger than STEMI population? And lo and behold, you do research because you don't know the answer. And the answer was it did not have a beneficial effect. It was the first 2x2 design, but I think the point was that unless you had total occlusion, lytic therapy was of little value. Then we jump about 8 to 10 years to TIMI 22, the Prove It trial, which was led by Chris Cannon. And that was, I think, maybe the most important trial up to now, because it showed that in high-risk patients who had ASCVD, that very intense statin treatment reduced adverse events compared to moderate statin treatment. And so that was responsible for the setting of 70 milligrams per deciliter as something that you want to achieve. That's the target in patients who have had a coronary event. And that seems to have stood the test of time. Then I'll go on to TIMI 28 Clarity, which was led by Mark Sabatine, and it was to look at clopidogrel um, in, in ACS and compare it to aspirin. And certainly, clopidogrel was more potent. So we were really on a roll with antiplatelet therapy. And then TIMI 38, which was led by Steve Viviert and Elliot Antman, showed that prasugrel was superior to clopidogrel. And then most recently, TIMI 54, Pegasus, led by Mark Bonaca and Mark Sabatine, ticagrelor in post-MI patients. So I think that these are the ones that really are my favorite children.
I mean, that is quite the highlight reel of truly impactful trials. And I have to say that as I hear you talk about each of these studies, one of the things that's striking to me is to think about the difference in scale, not necessarily impact, but difference in just in scale. So TIMI 1 enrolled, a couple hundred patients, whereas Pegasus enrolled more than 20,000 patients. So, aside from sheer difference in size of the trials, what do you think has been the biggest change in clinical trials over the last, 30, 40 years or so?
Well, I think that that they are much more rigorous. I think that if you would like to improve care, ultimately you have to get a new drug through the regulatory bodies, the FDA in the United States and the EMA in Europe, and I think the rest of the world follows these two. And they are very demanding, and therefore you throw in a lot of bells and whistles into the current trials, which makes them longer, and it also makes them much more expensive. But I think the information that you gather with biomarkers, with imaging, with proteomics, with genomics in current trials expand the information. It's very important.
What's so true, Dr. Braunwald, you look at these trials now, like the ENGAGE trial and nearing 100 publications coming out of the ENGAGE trial, and just so much information we can glean from these large trials. It really is helping the field in more ways than one. I want to shift gears slightly to touch on some career advice. Your work over the decades has significantly contributed to our understanding of hypertrophic cardiomyopathy, coronary heart disease, and valvular heart disease. However, I've heard that there was a point in your career where you made a decision to really focus in on myocardial infarction. And so I was curious to hear why you made that decision and if this is advice that you would give to early career cardiologists.
Well, I sort of told you the story of myocardial infarction. The fact that we were there on the ground floor to reduce infarct size, obviously, we didn't have the answer of the best way to do it. And in order for this to live up to its full potential and to reduce the mortality of one of the great scourges of mankind in terms of health, that we had to focus on something. And myocardial infarction seemed to be the logical place to go because we had taken what we felt was the first important first step, and built TIMI around that. With the passage of time, of course, our interests expanded, and we began to look at things that risk factors for myocardial infarction, for example, diabetes studies and other examination. But myocardial infarction remains the center.
Yeah, no, I think that is perhaps a nice lesson, which is that there's value in focusing and really advancing the field with respect to a specific disease, but also appreciating that that our understanding of that disease evolves, and that the questions that we have related to that, those initial questions, continue to evolve. And I think that sort of speaks to the TIMI experience over time. Well, as much as, the three of us, I think, love cardiovascular medicine and clinical trials, and we could probably ask you, I think, a gazillion questions. One of the things that we also like to do is ask our discussants about their families and interests outside of medicine. And so, Dr. Braunwald, if you're comfortable with that, I think our listeners would love to hear about, what you enjoy when you're not thinking about cardiology and clinical trials.
Well, first of all, most important of all is my family, my wife, my 3 daughters, my 7 grandchildren, and my 3 great-grandchildren, and watching them develop. One of my grandchildren defended her PhD thesis in engineering at Northwestern. It's just exciting for me to see her go through this on Zoom.
Congratulations.
And, yeah, my own personal, so family comes first. And then my own personal interest has been in classical music, which I inherited from my parents, and particularly opera. So when I was in college, which was at NYU, living at home, and medical school, which was NYU and living at home, I began to go to the Metropolitan Opera on the stage. I was an extra, so get dressed up in crowd scenes, and it was just an exhilarating feeling. And of course, I remained intensely interested in opera for, I guess, 75 years.
Wow, well, that's really cool to hear, and to think of you in college on stage. I have to ask, did you ever consider a career in acting or stage work?
No. No, I didn't.
No. Well, we're glad you did it. We're glad you did it, and that you chose cardiology. And we really want to thank you so much, Dr. Braunwald. It's truly been a pleasure to have you on the show, and we're all so fortunate to continue to learn from you every day.
Okay. Thank you very much.
Wow. That was really special.
It really was. I don't know that anyone will, ever have that kind of career in cardiology that he has had. If you think about how he started at such an early age and the impact he had early on, and then the duration of his career, the diversity and depth that he has covered, it's just such a unique and impactful career in so many ways.
Yeah, no, I mean, it is incredible in so many ways. And I think, like you said, what he was doing, at 35 was pretty incredible. Yeah, I mean, I can say for myself, I certainly wasn't looking for chief jobs at the age of 35.
No, me either. I was pretty content with being an instructor of medicine at 35.
Well, who knows? Maybe you'll win on the longevity front, Nick. Just keep your head down, keep your LDL low.
I like that.
And keep shooting for the stars, buddy. No, I have to say that I love the story about him first noticing that some MI patients have a stuttering course, and how that framed some of his thinking about the potential to intervene early in the disease. to me, it's really a good reminder of how simple clinical observations can really drive our research questions. And those research questions may ultimately fundamentally change how we understand and treat cardiovascular disease. What was the biggest takeaway for you from that discussion?
His passion and enthusiasm for cardiology, I think that's something that really resonated with me. And it's just so encouraging to see that it's still there after 70 years in the field. I think we're really lucky in academic cardiology to have these lifelong careers that we genuinely enjoy and they continue to develop over time. So I think it's just another indicator that we're in the right field.
Yeah, totally. There's nobody who exudes that passion more than Dr. Braunwald. Well, that seems like a good place to wrap things up for today. For the TIMI Talks podcast, this is David and Nick signing off.
Thanks for listening. The TIMI Talks podcast is hosted by Dr. David Berg and Dr. Nick Marston and produced by Kate Brennan. Like and follow us on Apple Podcasts, Spotify, and Google Podcasts, and follow us on Twitter @TIMI Study Group to be informed about upcoming episodes.